For me? Okay.
Two things, but you mentioned that sometimes people feel like they've got something stuck in their throat, and that happens to my husband, and it is really annoying, and he never knows what it is, but it feels like it's a pill, but it might not be a pill. What causes that? I mean, and how do you avoid it?
So I would certainly recommend, if he hasn't had a swallowing test done,
He
to,
he
to have
has.
it. If food is getting stuck in the throat, you should be able to see that on the swallowing test. And if not, so it's also can be a sign of reflux. So sometimes food is down here, but you feel it up here, just the way the vagus nerve runs through the body. So certainly we would make a referral to the gastroenterologist for that. But we would recommend, small bites, small sips, washing things down with liquid after. So if you take a bite of a solid, alternate with a liquid. It might be that he needs a double swallow, so a hard, dry swallow with nothing in his mouth after that first bite to try and help clear things down. Or it could be we need to change his diet. So if he's eating steak or like bread, that tends to stick a little bit more than like chopped up
Yeah,
chicken
we've gone kind of soft.
or like
Yeah.
fish or things like that. So diet modifications, room temperature water sometimes can help to wash things down. If it is related to reflux, talking to your GI doctor to see if you need to be on some type of reflux medication, making sure you're sitting upright, don't lay down for like 60 minutes after you eat to give your body time to digest your food, things like that.
The other question's about feeding tubes. I mean, I didn't think it was that big of a deal, except that you're not getting the pleasure of eating. But if you use it just for like your medication, I mean, does it get infected? Is there a problem with?
Well, it can certainly get infected because it's an open area.
Okay.
They teach you how to clean it when you get it. You have to flush it every day, or every time you use it with like liquid flushes or clear water to make sure, you know, bacteria and things like that aren't getting into the stomach because it's a clear path straight to the stomach. And it's just going to depend on each patient, the reason why they have the feeding tube. Some patients can't swallow enough to eat a whole meal. So maybe they take a few bites, but most of their hydration and nutrition come through the feeding tube.
We have a question in the back right here.
Well, pardon me. I have a question and a comment. My father had PSP, and he lived with us through his entire journey. And I used to be with CurePSP, the organization, several years ago. And one of the hardest questions is always about the feeding tube. And my advice to all of you is to talk about it early, because the downside is in the later stages of the disease, it's more of a difficult decision then. So it's a tough subject to bring up for the person with PSP and for their caregiver. Talk about it early. Decide if it's something you want. Read about a feeding tube. Read about what it does, and decide early if you want it or don't want it. And as you said earlier, you can change later on. As the disease progresses, you can always change your mind one way or another. But talk about it. My dad was too afraid to bring it up, and I was nervous to bring it up. And finally, we settled down, and we did discuss it. And I was so glad, because later on in the progression of the disease, I knew where my father stood. I didn't have to make his decision. He had already told me his decision. And another question now I do have for Dr. Cloud. One thing with my father, he and several other people with PSP, bowel obstructions. I didn't know exactly what was happening, what were the symptoms, what I was supposed to watch out for. Could you maybe review some of those things for us to just watch out for?
Sure, and I also just wanted to say that I think your comment about talking about feeding tubes sooner rather than later is really sage advice, and I think everybody should really take that point home with them. I think there's no more difficult situation for a spouse or a child, or a family member than to have to try to make those types of decisions on your behalf. So talking about it earlier rather than later and letting everyone know where you stand, I think is just so important. So thank you for saying that. So bowel obstruction can present in different ways for different people, but it is typically not a diagnosis that you're going to miss. You will typically experience pretty severe and increasingly severe abdominal pain. There may or may not be visible distension of the belly. There will often be nausea and vomiting with it, and inability to take solid food in. So this is not subtle. You're not, likely to miss this when it's in its sort of full form. But there's often a period of time leading up to that before you get to that situation, and that's where you really want to sort of catch people and intervene before it gets to that point. So anybody who is not having, bowel movements suddenly or has worsening constipation, and you're seeing a trend, you don't want to let that get out of control. You want to, bring that up with one of your doctors sooner rather than later. And it doesn't have to be your neurologist, your primary care doctor. I mean, they see this all the time too. So just bringing it up with some medical provider sooner rather than later is important. And certainly if you have any of those symptoms that we just talked about, go to an emergency room.
Dr. Cloud, I read my labels carefully, and on the psyllium mixture not mixture, but powder that I got from CVS, because it doesn't have the orange flavor, it says that you shouldn't take your medications within 2 hours to 2.5 hours of having that. Is that really, that's pretty restrictive, because, then you have to fiddle with that. Do you agree?
Yeah, so that's the curse of having PD. It becomes very hard to plan all your medications around one another and around food. I usually tell people the best time to take their psyllium is right before you eat a meal, provided that you're not underweight, okay? The reason for that is that when you take psyllium right before you eat a meal, it actually helps your body not absorb as much cholesterol out of the food that you eat, and so it would then have the added benefit of, helping with cholesterol maintenance. And most people who have Parkinson's disease are taking their levodopa. I guess it depends on your doctor, but in our practice, most people are taking it with food. So if you follow that guideline, you're going to end up separating the two anyway by virtue of, of the fact that your medications are going to be linked to your food. If you're one of those people who takes your PD medication on an empty stomach, then you're going to have to work something else out. But I don't think there's a one-size-fits-all, answer there. You probably don't want to take it with all your other pills, all at once. It's probably wise to separate it, but I don't know that it has to be at any particular time of day or that it's really all that important. Actually, Emily Perrin may have comments on that. Is there anything you want to add to that?
I think you've covered it. I think it's a bit neurologist specific in terms of the recommendation. I think it's also a bit of how you respond, like if you notice a difference when you take it near your medications versus not. It's really more a matter of, will it decrease the effectiveness of your other medications, not so much that it's going to be resulting in some sort of major crisis. It's just a matter of how do your symptoms respond, and do they respond differently. So, and a lot of it, we recommend separating it from other things that could also kind of bind up with it and not be as effective. But I think you covered it, Leslie.
I have two questions. One is Dr. Cloud. Some neurologists are saying take the Parkinson's medication with food, with a little carbohydrate. Some are saying without food, and some are saying with maybe a sparkling juice. So what should people be doing?
Do you want the long answer or the short answer?
The most efficient?
So the reason for the recommendation to take your levodopa separate from food is that when you eat protein, that protein leads to amino acids, specifically large neutral amino acids circulating in your body, and they compete with the levodopa for absorption into the brain. And so theoretically, if you take them at the same time, you could absorb your levodopa less well. So that's the theoretical reason for it. In reality, most people can take their levodopa with protein, even like a lot of protein, like you can take it with a steak, and still absorb your levodopa just fine. Furthermore, the main side effect of levodopa is nausea, and that is lessened if you take it with food. So most movement disorder specialists are going to tell you, just take it with food. It's probably fine. And if you find that you're one of those people who is very sensitive to that interaction, you will know, you will figure that out, and then you can separate it from food. But just off the bat, we don't usually tell people to do that, because then they're going to call 3 days later with nausea and not want to take the levodopa anymore. So we usually just say take it with food. And I even proactively tell them the pharmacist is going to tell you to take it on an empty stomach. Sorry, Emily. And they're even going to put a sticker on the bottle that says take it on an empty stomach. And I say just smile and nod and ignore them and do what I tell you to do, because otherwise, you know, nausea and vomiting become a common issue. You know, I think ultimately it's individualized. But I think that, you know, life is hard enough when you're taking pills every 2 to 4 hours throughout the day. To have to, you know, obsess about when you're taking it with food, if you can avoid it, I think just don't worry about it.
Okay, thank you. And I want to thank, I forgot your name.
Bobby.
Bobby, for stepping in for Ingrid. That was really great. And I just, for clarification, you just talked about the palliative team, and then at the end of the one slide, it was about the bereavement process. And I just, at UVA, they have the palliative team, which is for pain medication. They use it, a big part of that team is for pain management, and then palliative and hospice come in. And I guess my word to everybody here, when that time comes, don't wait for hospice the day before. Let them come in and help you early.
Yeah, I think when I was putting together that presentation, it's been a while since I delivered it, but it was something to the effect of the average hospice term in the U.S. is something like 10 to 14 days at most. So don't quote me on that, but waiting until the end, and then it's very complicated. It's more of a mess to bring that team in earlier, and then you can kind of prepare better for these changes toward the end of life.
Because they reevaluate you if they have to, and you can go in and out of it.
Right, it's not an end-all, be-all.
And it's your best friend for everybody.
So I've been working with a few patients who have been on palliative care for over 2 years and come to outpatient therapy.
A question right here.
First, I'd like to thank all three of the presenters this morning for the clarity and relevance of what they talked about. It was superb. On behalf of all of us, thank you. And then a specific question for Dr. Cloud, if I may. You talked about difficulty in motility in the oropharynx and stomach. Are there esophageal motility disorders as well?
Yes, yes. And you really need a good speech and swallowing pathologist to help you figure that out. But absolutely, most of the you know, studies are in the idiopathic Parkinson's disease and PSP populations, but absolutely both are observed. And you can have one or the other, or you can have both. And so it's important to get the testing to figure out where the problem is so that the treatment is targeted. And she may want to add to that.
Exactly what she said, and I would say involving a gastroenterologist, so a speech-language pathologist. When we do the modified barium swallow test, we get a glimpse of this area, but if there's something going on, that really is a different test, and the GI doctor is the one that would administer that. So most of the time for my Parkinson's patients, I say, hey, get a swallowing test and get a GI test, and I tell them to get that in the very beginning, so we at least have a baseline, because there's different things that cause swallowing impairments and esophageal impairments as well, so we can have something to compare it to at a later date.
Okay, everybody. If you have any more questions, our speakers are going to stick around through our lunch break, but it is time for lunch. So if you want to head back into the room with the exhibitors to say hello to them, grab a bite, you can bring it back in here, and we'll reconvene at 1 o'clock, I believe. Thank you.